What is the best way to evaluate mitral regurgitation when considering mitral valve surgery? How do we accurately and clearly assess the mitral valve to guide clinical care? That's exactly what we'll be discussing in this episode 10 of Tea Time. Welcome to Tea Time. I'm Dr. Andreas Plackis, and in this episode, episode 10, we're going to talk about TEE for mitral valve surgery, evaluating mitral regurgitation. The clinical questions we're going to be discussing today are, number one, how can a clinician evaluate mitral regurgitation with TEE to determine if a surgical intervention would benefit a patient? And number two, what echocardiographic parameters are used to define valve severity in mitral regurgitation? What specific interventions are there available for the mitral valve? Well, for the purpose of this podcast episode, we're going to focus on surgical repair and replacement, but there's numerous other interventions that can take place that we'll cover in future podcast episodes. These mostly include percutaneous options such as transcatheter edge-to-edge repair, annuloplasty, either direct or indirect, chordal repairs, or even valve replacement done transfemorally or transapically. This episode is not as much about what intervention we're performing as much as it is about when to intervene and why to intervene on the mitral valve in a patient with mitral regurgitation. A major resource that we have when looking closer at our mitral regurgitation treatment algorithms come from the 2020 ACC/AHA Guidelines for Management of Patients with Valvular Heart Disease. The first major differentiator of treatment algorithms comes by differentiating primary versus secondary MR. These are completely different treatment algorithms here. The next step that you'll see in these algorithms is differentiating the symptomatic patient from the asymptomatic patient. Other factors we'll look at this point include looking at the degree of LV dysfunction. Are they having other cardiac surgery? Are they a candidate for transcatheter edge-to-edge repair? And then is there significant chance of a successful repair if the valve is intervened upon? We just mentioned that primary versus secondary MR is the first major step when it comes to the MR treatment algorithms. Now, this is because these are essentially different disease pathologies, and the therapeutic options and outcomes differ between these two types of MR. For primary MR, think of this as a disease of the mitral valve apparatus. Is there something wrong with the leaflets, the chordae, the papillary muscles themselves? Whatever involves the mitral valve apparatus is a mechanical problem that needs a mechanical solution. However, with secondary MR, this is a disease of the ventricle or the left atrium. Goal-directed medical therapy for heart failure is the mainstay of treatment before we would consider surgical options in these patients. Let's start by focusing more closely on severe chronic primary MR. After you determine there's primary MR present, the next major step that informs decision-making is determining, is the patient symptomatic from this or asymptomatic? If they are symptomatic, it is a class 1 recommendation to perform surgery if they are acceptable risk for surgery. However, if they're high risk or prohibitive risk, a transcatheter edge-to-edge repair has a class 2A recommendation. When we look at the asymptomatic category, there's a couple different differentiators here. If a patient has LV dysfunction with an EF less than 60%, it's a class 1 recommendation to intervene on the mitral valve at that time. If they have a normal EF, but repair success likelihood is greater than 95% with a predicted mortality less than 1%, it's a class 2A recommendation for mitral valve repair at that time. The last category is that if you have a patient with normal LVEF with a progressively increasing LV size or decreasing LVEF on 3 or more serial studies, it's a class 2B recommendation to intervene on the valve at that time. As we mentioned, severe chronic secondary MR has a slightly different treatment approach. It's important to treat the disease of the ventricle. That's why the first major recommendation is goal-directed medical therapy for heart failure. Then you start looking at surgical treatment options. Some of the recommendations we see is when you find severe secondary MR at the time of CABG surgery, it's a class 2A recommendation to perform mitral valve surgery as well. If you have atrial MR with normal LV ejection fraction, it is a class 2B recommendation to perform mitral valve surgery. And then if you have a patient with ventricular MR with an EF less than 50% while on goal-directed medical therapy, you either differentiate between performing a transcatheter edge-to-edge repair if they are a candidate with a class 2A recommendation, or performing mitral valve surgery if they have severe symptoms and are not a transcatheter edge-to-edge repair candidate. I want to note that for the purposes of this podcast episode, we're not going deep into mitral valve repair or replacement decision making. That will occur in future podcast episodes. In Tea Time episode 9, we went over native valve evaluation, and I introduced a 6-step structure that you can use to evaluate any native heart valve. So we'll use that same system when thinking through mitral regurgitation. We'll start with step 1, looking at clinical information. When looking at patient clinical information, the first step we'll start with looking at is looking at patient symptoms. Are they symptomatic or asymptomatic? This is the first major differentiator in the MR treatment algorithms, as I already introduced. The next step will be performing a physical exam and looking at patient lab work. Are there signs and symptoms of volume overload? Is there an elevated BNP or even signs of organ dysfunction? It's important to note the heart rate and blood pressure at the time of the exam, as increased heart rates will result in increased gradients through the mitral valve during the exam. Hypertension can also make MR severity look worse, as there's a greater pressure gradient for a regurgitant jet. In addition, hypotension can make an MR jet look less severe. Since this is a perioperative TE podcast, most of these patients are under anesthesia, and it's important to note that anesthesia can change the exam of a patient with mitral regurgitation by decreasing the afterload or the preload in some of these patients. So when we make a decision about valve severity, we want to evaluate it at the same loading conditions as we would expect in the awake patient. If we need to perform interventions to simulate the awake patient, we can do this by giving an IV fluid bolus, performing an afterload challenge, especially in patients with functional and secondary MR, as primary MR is not as affected by anesthesia because it's a structural deficit. Step 2 in our valve evaluation is using 2D echocardiography. When evaluating MR, we have 3 main goals. The goals are to determine the mechanism, location, and severity of MR. I'll say it again. We want to determine the mechanism, location, and severity of MR. What is the defect leading to regurgitant flow? Where is it anatomically located? And how bad is it in mild, moderate, or severe? This image is very important from the 2017 ASE guidelines on non-invasive evaluation of native valvular regurgitation when it comes to chronic mitral regurgitation. It's a very important decision tree that helps categorize when we would classify patients as mild, moderate, or severe MR, and we'll use it throughout this podcast episode as an example to highlight some of the echocardiographic features that would put us in one of these 3 categories. Before we start our echocardiographic exam, it's important to remember a few key features about the mitral valve. The mitral valve is a complex structure that's influenced by many factors. This includes the anterior and posterior leaflet, the mitral annulus, chordae tendineae, and the papillary muscles that they're attached to, and then the underlying LV myocardium. Any of these things, when they're abnormal, can lead to abnormal mitral valve function. The anterior and posterior mitral valve are further subdivided into 3 segments for the anterior mitral leaflet, A1, A2, A3, and 3 scallops of the posterior leaflet, P1, P2, and P3. Different TEE views will show us different mitral valve scallops or segments. Depending on the view and your manipulation of the probe, you have a lot of different angles that you can see the mitral valve to assess particular parts of the leaflets. When we start our assessment by looking at the mechanism of mitral regurgitation, one of the most important factors here is looking at leaflet function. The mechanism itself can be characterized by Carpentier class. And we can also look at primary versus secondary here to further characterize in our head the mechanism of the MR. And as we mentioned previously, primary versus secondary MR have different treatment pathways. That's why it's important to characterize. Also, the Carpentier class will inform repair versus replacement decision-making. So let's look a little bit closer at the types of Carpentier class. There's 3 commonly characterized Carpentier classes, and then this other possibly listed type 4 class. But type 1 is normal leaflet motion. Type 2 is excessive leaflet motion. Type 3 is a restricted leaflet motion. And the other type, or type 4, we'll consider SAM etiology of mitral regurgitation. Carpentier class type 1 describes types of MR that have normal leaflet motion. These would include where you have a perforation in your valve. And if you look at that echo clip, you'll see a hole in that anterior mitral leaflet that's leading to the severe MR in this patient. There may also be clefts in the mitral valve, as you see a cleft in that posterior leaflet on the 3D image. Another type of type 1 Carpentier class is left atrial dilation. You'll see this in patients with chronic atrial fibrillation where you have a very dilated left atrium that dilates the mitral valve annulus, causing subsequent MR. Type 2 Carpentier class involves excessive leaflet motion. This first echo clip, a clip of flail posterior mitral valve due to a papillary muscle rupture, where you'll see that chunk of papillary muscle flailing into the left atrium. Flail leaflet is one of the specific criteria for severe MR. Other causes that fall into the type 2 Carpentier class include prolapse leaflets. You'll see in one of these videos the prolapsed P2 scallop. And then when you look at the 3D image, you'll see a prolapsed A2 segment itself. And then if you have multi-segment prolapse with flail, that's what's considered a Barlow's valve, which we see in our last echo clip. Type 3 Carpentier class involves restricted leaflet motion. Type 3A would be a rheumatic valve that is restricted in both systole and diastole, whereas type 3B is restricted in systole only. The last type here, which we mentioned is the other category, some people consider it the type 4 category, is systolic anterior motion of the mitral valve. You can notice this in 2D. I want you to train your eye to that little last second flick of the mitral valve towards that left ventricular outflow tract. And when you look at this with color, you'll see this characteristic Y shape to the mitral valve jet where there's turbulence out the LVOT and also regurgitant flow back into the left atrium. It's also worth noting that we'll see this in some patients after mitral valve repair, and that's why there's numerous screening criteria before a mitral valve repair to determine a patient's risk of SAM and if there's any further interventions that are needed to prevent this. We'll also look at leaflet structure to see if there's thickened leaflets, calcific leaflets, or vegetations on the leaflets. These also go into play when it comes to repair decision making. As valves that have vegetations or very thickened or calcific, you're much less likely to repair because of the difficulty and lower success rates with repair. I also mentioned previously the difference between atrial versus ventricular functional MR, and I want to further delineate between these two and how we can identify them on echo. Atrial functional MR is that type 1 Carpentier class. The mechanism for this is Carpentier class type 1, where chronic atrial fibrillation leads to left atrial dilation, which causes the mitral valve annulus to dilate and subsequently flattens the valve and minimizes the coaptation point, leaving a central jet. You have normal leaflet motion for these patients. Oftentimes you have a normal EF greater than 50%. The LV is non-dilated, and there's minimal tenting because the LV is non-dilated as well. Successful AFib management often treats and improves this type of MR, whether it's due to medications or ablation therapies. However, if those don't work well, a surgical intervention may be warranted. And in these patients that have a normal left ventricular size and just have dilated left atrium, a downsized annuloplasty ring frequently works well here as compared to ventricular MR, since the mechanism is annular dilation. And if you downsize that, you essentially address the mechanical problem that's been caused. Now let's look at ventricular functional mitral regurgitation. This is that Carpentier type 3B class where you have left ventricular dilation, whether it's due to ischemic or non-ischemic causes, that causes those papillary muscles to be displaced downward, and that causes mitral valve leaflets to be tethered apically and restricted, especially that posterior mitral leaflet. You oftentimes have that slightly posteriorly directed eccentric jet in addition to a central jet as well. Other associated findings that you'll see are an LVEF less than 50%. In this picture here, you may see this seagull sign because of the tethering that can occur on the anterior mitral valve, making it appear to look like a seagull. Lastly, I mentioned that tethering can occur especially on that posterior mitral leaflet, but a P3 tenting angle greater than 29 degrees is one predictor for valve repair failure that may push us towards wanting to replace the valve instead. As mentioned previously, goal-directed medical therapy for heart failure is the first and foremost most important part in treating this type of MR, since your goal is to treat the left ventricle, which is the problem here. Also, in ischemic MR, if revascularization is an option, if that's performed successfully, there could be LV remodeling and lower LV volumes that could improve the MR as well. Surgical options here include transcatheter edge-to-edge repair or that chordal-sparing mitral valve replacement that's preferred over a downsized annuloplasty repair. Step 3 of our exam is Doppler echocardiography. We'll use color Doppler to look at both the site and direction of the jet into the receiving chamber. A jet will move away from an area of excessive motion, such as a flail leaflet, whereas it will move toward an area of restricted motion, such as a restricted leaflet. You'll note here in this picture an eccentric wall-hugging jet that suggests moderate to severe MR. Other ways you can use color Doppler are looking at 3 particular jet components. Now, these 3 include the jet area, the vena contracta, and the flow convergence. Whenever you consider looking at jet area to quantify mitral regurgitation, noting if the patient has a central large jet greater than 50% of the left atrium, that is specific criteria for severe MR. Whereas if they have a small, narrow central jet, that would fall into mild criteria. There's a couple factors that can be influential here, such as when the patient has a flail leaflet, the jet area can actually be small and underestimate the degree of MR. In secondary MR, frequently these jets come through a slit-like orifice that appear large in a metaesophageal commissural view, even when the EROA is small in these patients. Measuring the vena contracta can be another helpful tool. You want to do this at the location of the narrowest jet width. That is frequently the metaesophageal long axis view. Also, this can underestimate MR if the jet is elliptical, as is frequently seen in those secondary MR patients. If the vena contracta is greater than 0.7 centimeters, that is specific criteria for severe MR, whereas less than 0.3 centimeters is specific criteria for mild MR. Lastly, we'll note that a large flow convergence seen throughout systole is also an indicator of severe MR. Using our spectral Doppler tools, we can further characterize MR as well. We'll use continuous wave Doppler to look at the contour and density of a jet in MR. If you look at this first echo image, you'll see that a holosystolic, dense, and triangular, which would indicate a V-wave cutoff sign that's early peaking with a rapid decay, is specific criteria for severe MR. Whereas if you have a soft or incomplete jet with continuous wave Doppler, that is mild criteria. When you use pulse wave Doppler, you can assess the pulmonary veins and look for systolic flow reversal. If that is present, that would be specific criteria for severe MR. This is specific yet insensitive for severe MR, and you want to measure this 1 centimeter into the pulmonary veins. Also, we'll be looking at transmitral flow. E-wave dominant with a velocity of greater than 1.2 meters per second would be characterized as severe criteria. You may see an A-wave dominant inflow. That falls into criteria for mild MR. We can use in step 4 of the valve assessment some quantitative measures as well. One of the quantitative measures we can use is assessing PISA for effective regurgitant orifice area calculation. I'm not going to walk us through each step of PISA calculation, and personally, I don't use this in an operating room environment, as I think the other tools that are recommended are more helpful here. The tool that I do use that you see in that 2017 ASC algorithm is turning my color scale down between 30 and 40 and measuring the PISA radius only at that point. And if that PISA radius is greater than or equal to 1 centimeter, that is specific criteria for severe MR. That is just one thing you have to measure. There's also less chance of error by the multiple things you have to measure to determine EROA with the PISA calculation. For people who do calculate PISA, can underestimate your EROA if the jet is non-circular. The PISA formula works for spherical structures, but if the jet is elliptical, it will only calculate that small spherical structure in the middle of the jet. Step 5 is assessing with 3D echocardiography. We will use 3D echocardiography to confirm our location of valve pathology. I do my best to determine this with 2D echocardiography and confirm with 3D echocardiography. You can use advanced maneuvers such as I-slice, multiplanar reconstruction, or other modalities to really pinpoint the exact location of the defect. Also, using 3D vena contracta area is a major tool to differentiate between moderate and severe MR when you have equivocal findings, but you need to assess the EROA in these patients. This is preferred to PISA calculation, especially in jets that are eccentric, multiple, or non-circular, and it's easy, it's quick, and it's reproducible to perform. I want to go over a specific example of how to actually perform 3D vena contracta area. This video goes a little bit quick, so feel free to pause it and rewind it if needed as well, but it shows you the basic steps for how to actually perform it. You'll start by acquiring a mitral valve 3D data set. And then you'll use MPR to align your planes with that mitral valve jet. Align the green and red plane parallel to the jet, and then the blue plane right at the site of the vena contracta. You'll zoom in on that short axis view in the lower left corner and trace that vena contracta area from there. After it's traced, it will give you a vena contracta area that is equivalent to your effective regurgitant orifice area. Step 6 and our final step is using other cardiographic data to inform decision making and characterizing MR. We'll start by looking at the left ventricle. If we have an enlarged LV with normal function, that is another criteria for severe MR. Whereas if you have normal left ventricular and left atrial size, that is specific criteria for mild MR. If the left atrium is not dilated, it essentially excludes chronic severe MR. Remember, every heart tells a story, and the story of the left atrium points to the story of the mitral valve. We're also going to look at the left atrial appendage, as patients with mitral valve pathology are more prone to clot in this location. It's more common with mitral stenosis, especially in low flow states, as MR is somewhat protective, but still worth noting. These patients frequently also have elevated pulmonary pressures. This pulmonary hypertension can also lead to RV dysfunction and associated tricuspid regurgitation. We'll characterize the severity of the tricuspid valve, as occasionally it's recommended to intervene on the tricuspid valve as well at the time of left-sided surgery in patients that have a dilated tricuspid valve annulus or previous signs and symptoms of heart failure. So let's round out this podcast episode by reviewing a few key points here. Point number 1, know your MR treatment algorithms. These are the backbone and the structure of why we would even evaluate the mitral valve. But knowing these can give you a framework to guide your clinical decisions when it comes to evaluating MR. Point number 2, echocardiographic valve severity is just one major component of the whole evaluation. Don't forget to look at the patient, to talk to them preoperatively, assess their symptoms, look at their lab work, and consider other features as well that go into the entire assessment of the patient. And step number 3, when assessing the mitral valve, you always want to walk away saying you know the mechanism, location, and severity of the MR. What is it? Where is it? And how bad is it? The next episode of Tea Time will be episode 11, TE for mitral valve surgery, evaluating mitral stenosis. Thank you guys for watching. If you want more of this content, hit that subscribe button, leave a 5-star review. That really helps us get this podcast out to more people. Also, if you do something different at your own institution, leave us a comment. Let us know what you do so that we can all learn from each other. But thank you again for watching. We'll see y'all next time.